Welcome to Eminent Psychotherapists Revealed by Psych Incubator. Tonight, we are pleased to feature Dr. Alexander Kriss, who is an Associate Clinical Professor of Psychology at Fordham University and Director of the Fordham Community Mental Health Clinic. He serves on the Board of Directors of the Westchester County Psychological Association and the editorial board of the journal Psychoanalytic Psychology. His writing has appeared in Psyche, Salon, and Logic, as well as various academic publications, and he is the author of two books, The Gaming Mind, A New Psychology of Video Games and the Power of Play, published in 2020 by The Experiment, and Borderline, The Biography of a Personality Disorder, published in 2024 by Beacon Press. His private psychotherapy practice is based in Sleepy Hollow, New York. Welcome, Dr. Kriss. Thank you so much for being here tonight.
Thank you so much for having me.
And I think I have the opportunity to ask you the first question, Alex. So it's great to see you. Thank you for spending the time with us. It's quite an opportunity. And I wanted to ask you about the Borderline book. It's a fantastic book. I think I mentioned as we were chatting that I've listened to it on tape, and now I've bought a hard copy so that I can actually give it to a patient of mine. And one of the things that I love about it is just the way it's written. It's just very easy to read and clear and elegant, really. And knowing a little bit about your biography, you've come. So this isn't your first, career or career pathway, that you had actually begun in learning about studying and practicing playwriting or in writing. So I just wanted to maybe start there. Very interested in, do you have thoughts about, well, certainly that probably helped in writing the book, I would imagine, but has it shaped you as a therapist, and how do you get to the therapy work from the writing, and what role does that part of you play?
Yeah. I trained as a playwright in college. I think it's not fair to say I had any kind of career. So this psychologist is my first and only career. But yeah, that's what I wanted to do coming out of high school. That's what I focused on in college. And it, all of my various interviews through grad school and going to externship and internship was always like, how did this happen? How did you get from point A to point B? Which, some of it was just a practical shift in my interests that I really liked studying writing and being in writing workshop environments. I don't think I appreciated maybe how much the social component of it was important to me until I was trying to write kind of on my own after college, and started drifting towards other interests and volunteer work in sort of on a crisis hotline and mental health that led me to then think about grad school. And when I got to grad school, I went to the New School in downtown Manhattan and ended up doing my dissertation with Howard and Miriam Steele, who work in attachment theory. And I did not know what attachment theory was. I'd been a psych minor in college, but had not been exposed to that much sort of formally by the time I entered grad school. And one of the things that I really was drawn to in the work that the Steeles were doing, and a lot of what attachment theory is centered around, is that so much of it is about analyzing people's narratives. And then more broadly, I came to understand how much psychoanalysis, which is sort of the tradition that I come from, is centered around that. And so in that way, it's very, it felt like a very logical move from being a writer where my interest had always, I think, been in how individuals structure their own narratives. Something that I came to feel in college when I was writing stuff is that I was not a particularly good plot person. I had a hard time sometimes coming up with like new stories. What I liked was sort of, exploring individuals in a given situation and sort of trying to understand their psychology. And in a psychotherapy context now, I feel like a lot of my point of view is centered around this question of trying to understand what someone's current self-narrative is, and how those narratives serve them and cause them to suffer, right, and where they came from and how they can potentially be deconstructed or rewritten. And so I think there are ways in which having a kind of formal education in like dramatic theory is an asset. I would love to teach like a playwriting for psychologists class or something someday.
That's great. It actually, just reflecting, I think that might be one of the reasons I have an instinct to buy the book for this particular patient, is because I think it will help with their narrative, honestly, to see that in the way the book goes back and forth between sort of history and describing borderline, but then the case, the amalgam of cases that you put together in a case discussion, that I think will help this person, gravitate to a narrative.
Yeah, it's
oh yeah,
sorry,
go
ahead.
go ahead.
Yeah, I think that's it's something I talk about with students a lot, that when they're doing intakes and sort of evaluations, right, which is often how students are introduced or doing their first work, is they're sitting down with someone gathering a history and trying to disabuse them almost immediately that what they're doing there is trying to gather facts, right? That rather we're not detectives, we're not fact finders. What you're trying to do is hear someone's story, right? If they tell you their history from birth to now, we will never be able to verify most of that information. It doesn't really matter. What we're interested in is how they have put the pieces together, and what that maybe helps us as clinicians know about them, and also helps them know about themselves as they actually hear themselves say it out loud.
Maybe before we should, if I get one more on the writing thing, as you're, thinking about a playwright versus a therapist. I mean, so much of the task of therapy is really deep listening, right? So have you thought at all about and I wonder, not ever having done any playwriting, but there must be some way to try to figure out what those voices are that would populate a play. So maybe trying to tune into who that character would be and listen to them, but on a different scale. I mean, in the way you kind of come across as a therapist in the book is extraordinarily tuned in and listening. So I don't know if there probably is a different element of listening in the work of therapy.
Yeah, I think they are different. There is, this really important, gets hammered into you when you study writing, the idea of thinking about subtext, right? That it's not dramatically interesting for people to just say what they are feeling, right? Or it's just sort of, say what their intentions are, or what they really want. That has to be subtextual. And it happens to work out that human beings are very subtextual. So when you're actually trying to get to know somebody in real life in a therapy context, you're often trying to listen for the latent content, which I think is part of the reason why both playwriting and psychoanalysis really resonated with me. I think I was predisposed to seeing, human nature that way, right? That we're multitudinous and multi-layered, and listening involves not just what is being said, but what is, meant, even if it is not quite being said.
It's so interesting. Yeah, go ahead.
Oh yeah, no, sorry, I keep cutting you off.
It's fine. This is your time.
I don't know if any of you are familiar with. There's a now quite eminent older Italian psychoanalyst named Ferro, who has a whole kind of concept around how really talking about people's internal objects and internal worlds in theatrical terms, right? And sort of saying that when somebody talks about, their mother, to try not to think of it as them talking about some person who's out there, but more that they've called the character onto stage, right? And trying to think about why, what is the dramatic purpose? What is the purpose in this moment to bring this character on stage? It can be, I think, a really useful clinical kind of heuristic when, especially with patients who maybe have really complicated lives and family stories, and you find yourself getting really caught up in trying to track the details, to sort of take a step back and sort of think more about what's the psychological or dramatic significance of this figure rather than the literal person who's out there in the world somewhere.
Okay, I'm going to jump off John's original question here. It's so cool that your background is like writing and then psychology and seeing how both of those two like interact for your, like, just the way you speak about it is so interesting. I want to know how you, or like, was there something specific that got you interested in borderline, in that component, or personality disorders in general? What kind of, like, did it just happen, or was there like certain things that happened that made you extra interested in it?
Yeah, that's a good question. I don't know. I mean, I think it happened pretty organically over time. When I was in grad school, I was really interested in working with pretty severe mental illness, and I had a lot of placements on inpatient and partial hospitalization type settings around New York City. And one of the things that I liked about it, and that I got some feedback that I had some knack for, was following psychotic processes. I'm sort of trying to understand the logic for people who are often being given the feedback that they make no sense. I mean, and sometimes I got the feedback that I was sort of, to use the word you said a moment ago, John, like so attuned that I actually then, when going back to rounds and reporting, I would underreport how disturbed they were at that moment, which was its own issue that I had to adjust and work on. So I think I was always drawn to trying to understand aspects of people's experience that are very hard to explain with language, and that eventually translated to working more with people who fall some broad sense within a kind of borderline continuum. I think in a lot of ways it sort of found me, I think, especially when I started my practice. So I had plenty of exposure to it in my training, which I generally feel like I had excellent training. But in my private practice, I honestly think like the fact that on my website and stuff, it said that I had a background in creative writing, and that I used language coming from my, feelings about, and some of my critical feelings about sort of diagnostic jargon, where one of the original bullet points, it might still be on my website, of sort of like, you might come seeking me if you like are in despair, or like feel like you don't know yourself. And then people would email me saying like, I feel like I'm in despair. I feel
Yes,
like
this is me.
yeah. And then I found a lot of those people were dealing with these kinds of issues that we maybe broadly call borderline issues. Yeah, kind of.
You attracted that
Yeah,
basically.
which says something about
Yeah.
me, surely.
Yeah.
But,
That's so interesting.
yeah.
So it just kind of, it happened organically through your work and the things you found interesting, and the things that maybe you were really good at, like being extra attuned to what people are saying, even if it doesn't sound like it makes any sense to anybody else.
Yeah, maybe. I mean, I think that there is something that I like about working with people who are in really high distress and in need of really firm boundaries. I think that, I know for some people, very understandably, that is unappealing for any number of reasons. I think that I can maybe get more oddly like on edge with individuals who are maybe more in the sort of neurotic space, where I kind of feel like they're already very all wrapped up, and it's a little hard for me to know exactly where I fit in or what role I'm serving. But I think it is such an idiosyncratic, the kind of work and people we're drawn to, right, says as much about us as
Definitely.
clients or patients. Yeah.
Definitely. Okay, one more question about kind of your path to where you are now. I'm so curious about your video game book, and for people who are listening and other people like me who haven't been able to read it yet, can you just like summarize something about it that you really like? And also how you got into that? That's so cool.
Yeah. So that I got into that because and I talk about this a bit in the book, especially, or I guess throughout it, but especially in the beginning. I got into it because basically when I was on internship, so at the end of my graduate training as a clinical psychologist, I was at Columbia Medical School, and a case came into the outpatient clinic where I was rotating, and the patient was described somewhat derisively or dismissively as a gamer kid. And I had been playing video games since I was a child. They've been a very important part of my life, though notably, as I also mentioned in the book, not something that I ever talked about in my own personal therapy, right? Not something that I had necessarily had any professional interest in, or none of my graduate research or anything had anything to do with video games. But this patient came in, and this gamer kid was presented. This was I loved my experience on internship. I thought this was like a group of smart, compassionate people, and they all seemed to be like not very interested in this kid. And I volunteered to work with him, and it sort of sent me on this process of thinking about it and working with him and starting to write about the psychology of video games and how we work with people who play video games as psychotherapists. And so the book, like, essentially, sometimes when I talk to people about it, I say like it's like a profoundly non-radical proposition, which is basically that video games should be treated like anything else we would treat in psychotherapy, as potential insight into the individual's psychology. And that the issue is that because of, for various reasons, why video games have accrued a certain stigma, which is, I've sometimes thought about how like both the two books I've written are about these highly stigmatized subjects in very different ways. People often are very dismissive of video games, and people who play video games are often very dismissive of them themselves. They have internalized this idea that they are a waste of their time, that they are rotting their brains, that it's, just kid stuff.
Negative connotation. Yeah.
So a lot of the book is about sort of through primarily a lens, also from psychoanalysis, of Donald Winnicott, the mid-20th century pediatrician and psychoanalyst, who had a very influential and I think really robust theory of play and what it means to play and why we play and how play gets destroyed, and sort of thinking about video games through that lens as a potential way for us to, and patients and others, to create space to explore different parts of ourselves that maybe we don't feel like we have access to in other parts of our lives.
So thank you.
I wrote a chapter in a book a while ago called, I forgot what the chapter was called, but it was an edited book called Transforming Negative Reactions to Clients from Frustration to Compassion. And I think one of the chapters in the book might have, sort of trying to tap into my memory network here, might have been about hate in the countertransference relationship, when you have like very intense sadistic or hateful feelings that are generated within us, and what that means for the therapist and what that means for the therapeutic process. Can you talk about what that's like as a therapist who works with difficult patients, challenging patients, because I'm sure those affects get stirred up in you at times. How do you deal with that?
Yeah. Yeah, I think there's multiple ways for us to talk about that. I mean, the first thing that comes to mind, right, is that one of the ideas that I really hammer into my students, that I think is generally a truism, in doing the kind of work that we do, no matter who you're working with, but can be especially true when you're working with patients who have really intense dysregulated affect, is how important it is to establish your own orientation and position as a clinician, right? It's where a solid foundation in which you understand what the work that you're doing is and where it's theoretically grounded, and how to sort of guide yourself through storms where it can be really easy to lose your way, right? So one of the the tradition that I come from, and there are obviously, when it comes to borderline and other phenomena, there's many different places that one could be looking at from, but my position considers what we might call the countertransference, or therapist's own reactions, to be this essential source of data, right? That it is can be looked at in multiple ways. It can be interpreting one's own countertransference as trying to understand what it's like to be with the person you're with. It can sometimes be about trying to understand what it's like to be the person that you're with, what they feel. it can be about trying to understand whether something that you're feeling might be a piece of the individual that they've disowned and are kind of projecting out and are communicating more unconsciously through you. So the long-winded way of saying, I think one of the ways that I deal with my own really intense feelings in session is having this kind of anchor point that I hold on to, that what I'm feeling is ultimately part of the clinical process. It is something that I am not trying to ignore or suppress, but think about and reflect and understand. And, there's this really important concept that one of the most influential theoreticians for me was another mid-20th century analyst named Wilfred Bion, who talked a lot about this concept of containment, right? And there's this idea that it's not necessarily our job to like resolve or soothe terrible affects and unnameable affects, but we have to contain them enough that they don't repeat past traumas. Hold on to them long enough that the raw material gets synthesized into something that can maybe be expressed through language. I have tried to work over the years on feeling what that is actually like, right? And I don't know, I think you've all experienced that in one way or another and have your own way of maybe dealing with the question of like when to say something versus when to bite your tongue because you're not ready to say something yet. Because if you were to say something, it would be coming from a raw place, right? That is not actually digestible yet for the patient. It's instead would be more lashing out, right? Reenacting something that was.
So I was going to actually jump in when thinking about the reenactment. So how do you understand projective identification in terms of when we're projected onto, and this has been pretty rare for me, but when I've been projected on so intensively that I start to feel that kind of negative reaction, and then the patient starts to say, you're abusing me just like they did. And I'm starting to feel like, oh my God, now I start to actually identify with the abuser. Is that a concept that you think is relevant in work with severely dysregulated, poorly contained people?
Yes, right. Because I think one of the major sequelae of individuals who have these kinds of issues that typically come from really disordered, chaotic, abusive backgrounds is that when you're raised in a fundamentally unsafe environment, a lot of the developmental energy that would otherwise be put towards sort of development of self in various ways, pursuing interests and hobbies during sort of middle, late childhood and developing friendships, has to be oriented towards attuning to other people in order to try to figure out,
How to survive.
How's dad feeling today, right? Like, is mom going to hit me? Whatever the case might be. And what that means is one's sense of self becomes indistinguishable from one's relations with others, right? That the self is diffused into dynamics with other people, real and imagined and everything in between. So this idea of projective identification where somebody not only attributes some disowned part of themselves to somebody else, right? Saying, I'm not angry, you're angry, which is more what we call projection. But this way in which the other person actually is sort of induced to feel a certain way or even behave a certain way in conjunction with this part of the person is really important if we think about that. One of the ways that these individuals maybe learn to survive is to create not just internal states that they feel are familiar or safe or comfortable or knowable, but dynamics with others that they feel are familiar. And what is familiar is not necessarily what is healthy, or it's often recreating something that was actually maybe quite traumatic. But something that comes up a lot in my work with these kinds of patients, right, is that there's a real urge to draw out the sort of sleeping Leviathan, right, to bring anger to the surface, for me to a wish that I would show them that I am an abuser, because then it's like, well, then they can see where the danger is, right? That is, if I'm a bad guy and they know it, then they don't need to worry about something else sneaking up on them. But if they're in an ongoing relationship with a therapist who doesn't seem to be fitting into their template of how people treat them, then on the one hand, that's great, right? They're maybe having a more compassionate dynamic than they've known, but then it raises the question of like, so then where's the wretchedness, right? Where's the badness? Where is it hiding? Is it in me, right? Is it hiding in him and I just haven't seen it yet? And it can become an incredibly anxiety-provoking experience for the patient, and potentially also the therapist. I had a patient the other day who we've been working together for a few months, and there was a pause in the session. She just looked at me and said, "What's your deal?" Right? And it's just this like, you're not fitting into any of the boxes. And that is not an entirely pleasant experience. I don't know if I got away from the projective identification piece, but.
Well, I want to sort of add to that a little bit, and and as somebody that's training people, right, in the field, on Jeff's question, do you have thoughts about the process of, obviously people go into this field to try to help people, so they don't like to identify a feeling of hate within them for a patient, right? So, and in my own experience way back in training, I still remember the moment when I sort of felt it was okay to feel that feeling in the room. Do you know what I mean? Mm-hmm. And that freed me up. So the resisting of that, in a projective identification or whatever, which is inevitable. I mean, where the enactments are inevitable. I mean, even in your work with students or in yourself, was there ever because obviously most of you do want to resist it. I mean, when you feel like you're being pushed into the identification part, you don't want to do everything you can to understand it ahead of actually identifying. So it's fine to resist it, but if it's all resistance because you're defended against the actual feeling, that's not going to help anyway, right? So how do you think about that, or how do you teach about that?
Yeah, I think that idea of tolerating your own negative emotions and tolerating potentially being sort of the bad object, right, in the other person's mind, right, that there might be a period of time in which the patient sees you as sadistic, right, or sees you as abusive or unhelpful or incompetent, is incredibly challenging experience for trainees, right? It's they already are so worried that they're incompetent or hurting people. Like it's of course they just want everyone to get along. I recently had a conversation with a student who told me, when she was in a seminar with me a couple of years ago, so now she's now quite advanced in her training, and she said, the most helpful thing you ever said to me was that it's not our job to be nice to our patients. And it's not necessarily like intuitive when you're starting this work that there is a real difference between being sort of friendly and supportive and doing mutative psychotherapy work. So yeah, I think that I'm trying to think of my own experiences. Like I mean, I had one very formative experience when I was working at a college counseling center in sort of the middle of my graduate training, where a patient, I thought we had this like great rapport. We had this kind of like fast talking, really maybe a little flirtatious, back and forth. She was very intellectual. And then after we'd been meeting for a while, I got a notice from my supervisor or someone at the front desk saying she's requested to switch therapists. And I sat down with her and I said, like, listen, I heard that you want to switch therapists. I want to know what that's about. And she said, like, she's like, what is it about? Like, every moment of this is complete agony for me. Like, this has been the most like invasive, piercing, unpleasant, intolerable experience for me, and I can't bear it anymore. I want to be with like a nice older woman or something that is like not you. And the pull to, be like, "Oh, I'm a nice guy," like to defend myself was so strong. And I'd never been confronted with this kind of exchange like live in person before. And I think I was torn between trying to defend myself and trying to be just sort of like, fine, go away and like go be with somebody else. And I don't know how I came to this. I mean, it's a credit to my supervisors and training that I had up to that point. But what I managed to say to her was, we could stop, but then I'll just always be another asshole guy that, was horrible to you. Or we could keep going and we could see if maybe that's not the case. And I can try to understand more about how my behavior has influenced your assessment, right? We can like try to work on this together. And this idea of like, I'm not disagreeing with you. I just think that maybe we could give it a little more time. And that was, in that case, it was very effective. And that was this kind of eye-opening moment of like, oh, I don't have to like make my case that I'm like well-intentioned. Like this can happen at its own pace. And patients can sort of decide for themselves what they're willing to tolerate. And I try to impart that, right? This idea of slowing down, tolerating affect before we like decide what it means or what to do about it. I try to talk about that with my students whenever this kind of thing comes up.
My association to part of that, Alex, was when I was in residency. One of my good friends was in psychoanalysis and discovered and shared that the therapist has the words "the rapist" in it, and which, in a sense, kind of, there's also a part of this which is just the frame, owning the and getting to a point of owning. This is tough for trainees. That inevitably there are things that we do as part of the frame that are just awful, to going on vacation, and you talk in the book about having a kid, like, and just it's easy to not. The worst scenario, of course, is you can't own how destructive that is. I mean, you have all the power in that moment, and which actually, I do want to get a little bit to the diagnosis of borderline personality disorder, which clearly is something that is important to you, and one way to actually, one question is, how do you talk? All of our diagnoses are in some ways a negotiation, right? Like, we don't yet have a blood test that says you have depression even, right? And I have all kinds of metaphors, and if you had it and we had an x-ray, this is what it would look like. And literally just before this meeting, I was with a patient who is in a depressive episode, and I had to do a lot of metaphor work to try to figure out how to get that across. So, but borderline's even a level up in the valence that it has, the impact that it has, and the controversy that it has. So, just to start with, how do you talk with patients about it? Let's say you're wanting to let somebody know you think that that's what they have. I mean, how do you talk with them about it?
Yeah. I mean, it's tough like that. The idea of the use of metaphor, which I use a lot, like, it's like language is all that we have. Like, that is our tool in psychotherapy. It's and some things are really hard to describe, and diagnosis is a shorthand, and it can provide a common language, but it can also be incredibly reductive. And there can also be this idea, which is not just like a patient-generated idea, an idea that sort of the mental health establishment really pushes, that it is in some way like definitive and objective, rather than it being a negotiation, right? And an attempt to find the best fit for the individual, rather than trying to fit the individual into some pre-existing box. So, when I talk with patients about diagnosis, it looks different. Some people come to me with pre-existing diagnosis, but then, in any case, in that case, and I tell this to trainees a lot, is like, if anybody comes in with mental health language, like, don't assume that it means what it means to you, right? We have to understand what these things mean to the individual. And also, like, what did their last, provider explain or not explain, right? Or what was their idea of what these things mean? that it can be a real trap to feel like we have common language before you've actually established that with your specific patient. That you know, that a term like borderline carries a lot of weight and stigma, but you know, even some patients, to say that they're depressed, right, to them that means like this is something that will never get better and never go away, like, because for whatever reason that is the association they have. And so with the talking about borderline, I mean, I do honestly explicitly say, like, first of all, don't Google this when you get home. Like, if you can resist it, I can't tell you what to do, but like, if it's possible for us to talk about this a little bit more before you see what else is out there, because it's this really, I feel very conflicted about it, because I think that the value of using the borderline diagnosis is that there is, as I read about in the book, you know, century or more of knowledge that we have about these experiences and this condition, and to throw away the term entirely is to potentially lose track of the accumulated knowledge, which has been lost and sort of reassembled or misappropriated in all kinds of ways as our diagnostic systems have changed and paradigms have shifted. But at the same time, I understand that for a lot of people, it feels like I'm branding you with just a straight up socially undesirable label, that people consider, you know, the colloquialism on Reddit and other places that BPD stands for bad person disorder, right? That it is being branded as just difficult and untreatable. So I try as much as possible to talk about this idea of like, the patient and I, we need to come up with a common language. This term doesn't necessarily have to go on in any official documentation. We don't even have to agree that this is the term that we use, but this is a concept. I want to explain it to you, and it is something that we can explore together. I think it's most useful to introduce the explicit sort of diagnosis when you're dealing with individuals who are coming in with like a slew of diagnoses, right? Someone coming in saying that I've got anxiety and depression and ADHD, and I'm on the autistic spectrum and all these things. And sometimes it feels like, well, what if we consider that there's actually like an umbrella that covers a lot of your experiences without you feeling like you're being pulled in a million different directions? And that for the potential cost of that diagnosis, we might actually be helping resolve a lot of distress, helping explain why a lot of other treatments haven't worked, explain why the person has never really felt understood. So in those cases, it's, you know, sort of like there may be very real arguments about not telling someone that they have BPD, but if the alternative is that they're walking around thinking they have bipolar disorder and they don't, and they should not be given medication or have treatment that is oriented towards that, like, then you have to have that kind of conversation.
So so just to take another position here, what about, instead of using borderline personality disorder, we consider most of those people fitting into sort of a kind of a complex post-traumatic or developmental disorder that's just seems less.
Yeah.
So I've gotten away from, I've written a lot of books on personality disorders, and one of my books, I didn't even want to use the word personality disorder. I put personality dysfunction. I think that all of us at times under stress have dysfunctioning personality systems. So if that's our kind of operating system, if it's overloaded, we need to reboot sometimes. And so to me, where I've gotten in after doing this work for decades is to the point where I say that I really think that what you're communicating to me and what I'm understanding is that you've got untreated trauma that's been developmental, and it's just layered and layered and layered with patterns and patterns and patterns. And does it fit some of the criteria of narcissistic or borderline personality disorder or pet? Yeah, it does, but it's I think important to understand that, like, what happened to you, not what's wrong with you. Like that book that Bruce Perry wrote with Oprah, which I love, is like, what happened to you, not what's the matter with, what's wrong with you. How would you?
Yeah, I mean, I think there's a really strong argument for that. I've been gone back and forth. so I mean, I have a couple thoughts. One is, if we as a profession want to really embrace CPTSD, or complex PTSD, like I'm all for it, but then we have to merge the two, right? Because what has happened is that CPTSD was derived in the work of Judith Herman and other trauma theorists in the 1990s, working with borderline patients. And then over time, there has been this growing literature that separates the two and creates this gatekeeping effect, which is one of my major issues with trauma labeled diagnoses, is this idea of you get to have this diagnosis because there's some verifiable thing that happened to you. And if you don't have that, then you get labeled as this sort of bad person. And so if we really move towards a conceptualization of chronic trauma and developmental arrest, which I think is really appropriate and is the etiology of borderline phenomena, then we need to let everybody into the tent, right? And avoid there being this schism where some people get one label and some people get another, right? Like literally, I think we would have to remove one from the DSM and from the ICD and say that all of those people belong actually under this category. So that's one thought. My other thought is, I mean, I'm of a really mixed mind about it, because I think that is really important to think about someone's present struggles in terms of what happened to you. But I also think it is really important to think about what does it mean now, right? And what the
of
I mean, not
course.
to say, I don't mean to say that you're not saying that, but the borderline label, right, being, or the term borderline, and I sometimes more than disorder, like Otto Kernberg's notion of a personality organization, right? That these are principles around which someone has structured their life, rather than it necessarily being a disorder, right? That it is illustrative
So can you
of
say
how
more
we
about
function.
that can you say more about that for our listeners? Because
Absolutely, yeah. So
that's such a useful psychodynamic treatment diagnostic manual to me is so much more informative. But can you say
agree, yeah.
about structural?
So yeah, one of the great ironies of BPD is that the term comes from this conceptualization, but was lost when the DSM-3 was introduced in 1980 and purged of psychoanalytic language. So the term borderline in Otto Kernberg's usage is rooted in a concept of personality that ranges from the psychotic to the neurotic, right? And one of the things I like about this is that it's, and the psychoanalytic perspective in general, is this idea that like we're all neurotic at best. Like, we can't escape some version of our personality being organized around ways in which we defend ourselves against intolerable anxiety. And so some of us do so in a pretty rigid, predictable way. And some of people really struggle to defend at all and are in a kind of state of more chronic diffusion and looser boundaries between sort of inside and outside and fantasy and reality, who we might call psychotic. And then there is a position in the midpoint, the borderline between neurosis and psychosis, where individuals in a stable, consistent way participate in defending themselves both through more rigid and developmentally mature means, and some of the more primitive means that are available to us starting from birth. And so when we think about people in terms of that, we're not saying it's less oriented towards their disorder, and it's more about what are the intrapsychic internal tools that they pull on when they're overwhelmed. It can be really useful when working with borderline patients because it's a way of basically saying, like, this, when you're in one of these states that's so overwhelming, like, that is not your personality, that is not who you are, right? That is the part of you that gets activated when
That's a regulatory function.
Exactly. Yeah.
So just for our viewers' sake, the work of Nancy McWilliams is very informative around this topic of psychodynamic diagnostic sort of conceptual.
You mentioned the psychodynamic diagnostic manual, which I think is, I keep a copy at Fordham where I teach. I think that students should be exposed to it much more than they are. And Nancy McWilliams, it's worked on multiple editions of that, as well as written her own books that I think are incredibly
Classics now.
readable. Yeah, I mean they are so enduring and popular because I think they explain psychodynamic concepts in a really digestible way.
And it's also because she's one of those therapists who most people, when you meet her, say, if I want a therapist, that's the person I want to see. She's awesome.
Which is how you come across Alex in the book, and here too. And to pile on with the problems with borderline personality disorder as a diagnosis, which has bothered me. And Jerry Fromm is somebody that's done some writing on this. Is patients don't come in and say I feel borderline. They come in and say I feel depressed, I feel anxious, I feel paranoid, I feel. So there's something oddly, what does it do? It kind of locates you on a continuum. It misses something about, to Jeff, to your point, even trauma, like people can say, I feel traumatized, but what does it mean? And what is it? So when you were describing it before, Alex, and you said this thing about it's an umbrella, for like that's useful. To me, one of the ways that this diagnosis might be useful to you is it provides a container for what you're experiencing. The two couple of metaphors that I end up using with patients and families with borderline. One is this idea of it's really around projection. It's people getting filled up with toxic psychic material and they just leak it. And it's actually an adaptive thing that's evolved over hundreds of thousands of years, probably, because if you couldn't leak it, it might kill you. And that is somewhat helpful, especially to families, but sometimes to people suffering with it. The other is this, the psychological muscle that's really out of whack is the one that allows you to utilize other people effectively, or to have them work for you, or do things, with you to succeed, kind of thing. Like that's totally out of whack, like.
I mean, I love that, especially one of the psychoanalyst named Lisa Lyons, who mentored me for a year, many years ago. One of her sort of ideas around borderline phenomena was like, everyone says that borderline patients are manipulative. It's the opposite. The problem is that they have a hard time manipulating
Totally.
people. They don't know how to do it. It's too obvious. It upsets people. The rest of us, we're the manipulators. We figure it out how to get what we want in a more subtle or socially acceptable way.
And
Yes.
once you see that, once families see that, they can have empathy,
Right.
because it's just so sad to see, and no one would want to be like that.
Yeah, exactly.
So what do you think about Ted Milan's idea that our personality is our emotional, psychological immune system, and that the structure of it is either robust and we have good immunosuppressant stuff and it works well, we can metabolize, you guys are talking about taking in and metabolizing or projecting. And so what do you think about that notion that it's our psychological immune system?
I mean, does that imply then that there's certain aspects that are immutable, right? There's just sort of some people are born with a weaker immune system, and they have to learn how to deal with that rather than try to change that?
Accept it, figure out how to compensate for it. Like if you have schizophrenia, your immune system is not functioning at a higher level psychologically because of some probably biological or genetic predisposed kind of.
Yeah. I mean, I think that there's there's potentially utility in that. I think that a lot of the struggle with individuals emerging from chronic trauma and dealing with sort of borderline issues is that whatever their personality might be, or the immutable aspects of them might be, they feel very far away from them. They don't understand them or know them. They didn't have space to get to know themselves in that way. So the idea that like some aspects of their personality that are causing them problems are also really aspects that might make them exceptional or special or who they are, right, are ideas that maybe have to be explored for the first time in therapy. Often encounter people who are in the midst of careers that don't really make sense for this person, right? That they and people who feel like they have a hard time identifying what their hobbies are, what their interests are, and so this idea that they're maybe had an immune system, a personality structure that was predisposed to some of these issues, there's still the challenge of disentangling, like, what is a reaction to extreme traumatic experience versus sort of what you're naturally inclined towards, right? And what would be a good fit for you in terms of relationships, in terms of, work, and in terms of other things. That is often a big part of the therapy process, right? Is people, once they get a handle on some of them maybe more extreme affective storms or behaviors, is this question of like, okay, so like, who am I? What do I want to do with myself, right? What would actually be not just scraping to get above water, but actually something that feels like, to quote Marshall Linehan from a very different tradition, a life worth living.
Moving from survival to thriving.
Right. Right. Which is perhaps a possibility that a lot of these people had never even considered was available to them until they reached something closer to a sense of calmness or stability.
I know we're kind of getting near the end, and this is maybe switching gears a little bit, but also going back to the power dynamic around diagnoses, And I imagine, Alex, well, probably most of your work is in private practice. You might not be using a big electronic medical record.
Right.
But I do work in a big health system, and most healthcare happens in big health systems, and we use electronic medical records. You may or may not know that over recent years, there's been, the law is driving toward transparency in the medical record, so that it is, I don't know if it may be every state now that has to allow patients to have open access to their notes, including psychiatry notes. There's some, process notes you can, as a therapist, keep private, but otherwise, this is made for very interesting stuff, right? So even on an inpatient unit, if phones are allowed, and if the patient has a portal, they can read the notes that are being written that day about them, right? So, I mean, as we're talking, I'm thinking, wouldn't it be interesting to track certain diagnoses like borderline happening less and less as our patients actually have, and we can't keep that private, right? I mean, I'm actually sitting, my office is at the Institute of Living in Hartford, Connecticut, 200 years old. There are nurses working today that remember that they weren't allowed to know that the nurses weren't allowed to know the diagnosis in the treatment of a patient in this institution. So who knows, who gets to know, who gets to create the language and that defines, is very much in a very different spot now. I don't know if you've thought about that as it relates to borderline or other stuff.
I mean, it's super interesting. Yeah, I don't think in New York we're at that. I don't know if that's the open medical record is the norm here, but and I most of my work is in private practice. And the clinic I direct, the training clinic I direct at Fordham, because we're a training clinic, we don't deal with insurance, so we are much more. We're not under the same pressure to give diagnostic codes and things that that you are, right? And that I often have to do in private practice for people who are submitting for insurance reimbursement. Yeah, it's super interesting. I mean, generally speaking, I try not to make large, broad statements, but I am a big fan of transparency, and I think that our profession could use more of it.
Yeah,
right? I think even if part of what that does is it exposes how differently we behave when we know we're being watched, right? Like that is that alone might have some significant impact on how we organize our diagnostic system, right? And teach it and so on. So I could imagine, all kinds of, issues and bumps in the road. But in general, I think if we can dismantle this sort of this opacity between doctor and patient, while still allowing doctors to maintain a sense of having expertise and bring, you know, value and a point of view to work. I think it's maybe broadly a step in a positive direction.
I'm going to try to squeeze in one more question for you. If you were to give words of wisdom or advice for professionals just starting off in the field, what would you tell them? Or what do you tell them?
I guess the thing that comes to mind, and you know, this connects, I guess, back to my background as a writer and things we were talking about before. Like I really try to encourage students, people who are considering entering the field, who are trainees in the field, to try to have varied, rich lives and interests, right? That it's so many of the doctoral students that come through our program, because these programs are so competitive. I couldn't get into them, you know, now. You know, they've had this laser focus since they were like 18 years old or earlier. And they come in, you know, sometimes I've been on webinars with other programs who are like, we expect our students to like know what statistics they're going to run, you know, like on their dissertation, like when they're applying for grad school. And so a lot of these really bright students that have learned how to do that, right? And present themselves as like a full developed package. And then they come in, and I feel like part of my job is to tell them to forget all of that. You don't know anything yet, right? And you have to, like, you're here to explore and understand who you are. And that can happen ideally in grad school, but I think it's also so important for, you know, trainees to like go to the movies and like, you know, keep reading fiction and, you know, be
Go to art museums, paint.
Yes, exactly.
Yeah.
So that is based on what I sort of see among the sort of trainee population, that's sort of maybe the most practical advice I could offer.
That's great. I mean, I think we ask this to almost everyone, or at least try to, and usually the responses are like, seek supervision, you know, talk to your colleagues, and that I don't think we've heard that response yet. So have a rich life, have hobbies, do all that. That's a great answer. Yeah.
So do you think that in your experience in working with trainees and in your own development, that most of what it takes to be a therapist is something that you're born with, or do you think it can be developed? Or, I mean, I just did some research on therapist harm, and some of the studies suggest that about 40% of us actually do harm. So what's your take on that, Alex?
I mean, I think it's such an important question that does not get enough attention. I was just talking to a student earlier today, who a supervisee of mine, about how, you know, one of my real issues with the evidence-based treatment movement is that it is so centered the treatment as the thing being validated, right? And the treatment works, and the treatment is being applied to the patient. And if it doesn't work, they need a different treatment. And there's so little consideration for the therapeutic relationship or the talent of the therapist, because it's anathema to the randomized control process, right? Therapists, we can't systematize that. We can't standardize therapeutic dyads. And so it has not gotten, I think, a lot of attention that it deserves, because I do think there's such a thing as aptitude and talent. And I think it's really important that trainees be exposed to many different modalities so they can find points of view that resonate with them. Because I say to my trainees all the time, and I'm in a program that I'm sort of this psychodynamic voice, but it's very cognitive behavioral, and we have neuropsych specialists. And I often say to my students, like, if I was doing CBT, I'd be a terrible therapist. Like, it's not my point of view. I would be bad at it. And you need to find your point of view. So I think that there's, I would love to see that more in our discourse, right? This idea of how do we deal with the problem of individual differences and, you know, therapists' personalities and so on.
Well, that sounds like a good task for us to all be working on. So, Alex, thank you so much for being with us. This was
Yeah,
very,
thank you for having me. Yeah,
Thank
this is a lot of
you.
fun.
and we appreciate your time and your expertise, and we'll hopefully be able to spread this to a lot of people who are seeking experience and advice and models. So thank you very much, and thank you for those watching, and we'll see you next month.